Thank you very much. As she told you, my name is Connie Arnold. I'm from LSU Health Sciences Center in Shreveport, and this is my disclosure slide, research funding. And these are the goals that I want to do today we've talked a lot about implementing health literacy in clinical trials, and what I want to talk to you about are two particular clinical trials where we implemented health literacy. My colleague Terry Davis and I did on colon cancer screening in predominantly rural areas. We had an NCI R01 from 2007 to 2012, and then we had an American Cancer Society grant from 2012 and 2018. And beside the outcome of the studies, what we wanted to talk about in particular was what worked and what didn't, what went into it when we did it, and the challenges and lessons that we learned from both of them. So the first study that we did was the R01, and this was a 5-year study that was looking at 8 FQHCs to look at breast and colon cancer screening. I'm only going to talk about colon cancer. But one of the things that, to back up a little bit, is that whenever we have done grants with rural areas, and we've done an extensive number in federally qualified health centers, is before we ever write the grant, we call the CEOs, we set up a meeting, and we drive out and meet them and whoever on their staff, and we have long discussions about what's going to work in your clinic, how is this going to go down, how do you see this going on, because as my colleague Terry Davis always tells me, it's all about the relationship. And really, when you're working in clinics that you are not a part of, it is all about the relationships, and they need to be on board. They're much more capable of telling you what is going to work in their clinic, how this is going to work with their patients. And so that's how we started it. One of the things you have to remember, though, is as researchers, we're used to, you write a grant, you don't get funded the first time, you resubmit. You know, it's 1.5 years to maybe 2 years after you sent it in. Well, federally qualified health centers and community clinics are not used to that. And so one of the keys is to keep them involved in the process. You know, we were very clear and very upfront with them about, okay, this is when it's going to be submitted. This is how long it takes to get reviewed. We let them know what the results of the review were. We're going back in. That was very important, because otherwise they forget who you are. You know, after 2 years, it's like, oh yeah, we did talk about that. And so for those of you who don't know what federally qualified health centers are, they're government-supported clinics. They provide services up to more than 20 million people, regardless of their insurance status. And they're generally located in areas that are medically underserved. And so for this study, our target was 5 FQHCs in predominantly north rural Louisiana. And so as this map shows you, these are where our clinics were. Shreveport, for those of you who don't know, is right up here in the corner. And so this is just kind of the study clinic demographics. We had 67% African American, 32% were white, 56% read below an 8th grade level. And so what went into the health literacy materials and the development of, well, we had built in focus groups into the study to do with patients and providers in developing everything and testing everything. So we did focus groups to develop the brochures. We did, focus groups we tested out, we pilot tested surveys. I mean, one of the mistakes people often make with validated and reliable surveys is they oftentimes in the past have been done on college-age students. Are you asking what you think you're asking? Does the patient interpret the question the way you've asked it? One of the things we did in the study that I didn't do a slide of is we had a laminated Likert scale, and it was done vertically because we wanted patients who have low literacy to be able to discern the difference. When you put it horizontally, everything kind of looks the same. So we tried out, we asked patients which ones they would like. And so we used a vertical scale so they could point to a difference and whether how strongly they agreed. Later on, we called it the two-step process that Mike Wolf and Terry had developed, which was what we found out in a lot of our studies is patients often with low literacy would always just say, I agree or disagree. You never could get them to say strongly agree or strongly disagree. And so what we taught research assistants to do was to ask, do you agree or disagree? And then they would say, well, I agree. Okay, do you just agree or do you strongly agree with that? And so to break it down to where they picked a choice and then they picked another one. We also developed a short video that the patients helped develop. It was their idea. The women wanted a soap opera type study video, and so we did it, and we needed to get a place that it seemed realistic in Louisiana where you had African American and white women coming together. So they suggested bingo. So this was done in a scenario of bingo. It actually showed a woman getting a mammogram. It broke away from part of the discussion of women having about mammogram and colon cancer screening. For the men, it was eating breakfast in a rural cafe. We simplified the FOBT instructions at that time with patients' help. And then there was also a nurse case manager arm. And so those are the brochures that we developed in 2007. The one on the left is the colon cancer screening ones. The one on the right were the mammogram ones. The inside pictures were our patients. Now, these were stock photos, which in the subsequent study we did away with. But these actually were patients. This was one of our patients getting a mammogram. These were physicians in the clinic. So we tried to incorporate all of the principles we know about health literacy, about what was going to resonate with the population that we were working with. And so it was a 3-arm study. You had an enhanced usual care and it was enhanced because they were given the FOBT or they were provided the mammogram. You had a health literacy only arm that they were provided the health literacy materials. The research assistant demonstrated it. And then you had a health literacy and nurse arm where you actually had a nurse who followed up. The other thing that we did was we did in-services with these clinics. Because even though the provider only had to make a recommendation, everybody on board in these clinics needed to know what was going on. There was a research study going on. We wanted to introduce them. One of the things that we found out in these rural clinics was that was having to hire a research assistant. To enroll 3 or 4 or 5 patients a week, you don't need a full-time research assistant. And so we worked with the CEOs to go, what is going to work best in your clinic? Because we can train somebody to do consent. We can come down and in-service them on how to distribute the materials and how to give the questionnaire. None of that was so complicated that we couldn't do that. And so most of the clinics chose to use a staff member who was already had some time. A lot of times this turned out to be a lab technician, because in rural areas, it is really hard to find extra employees. We did hire one person that was not originally in the clinic. This is Terry and I's running joke, because they kept telling me she was calling in sick, and I go, okay. I said, do what you need to do. And finally, I used to have lunch with them, and so I would meet them somewhere, the research assistants, and one of the research assistants at that's a little town 5 miles up from it was the only one who showed up, and he said, well, we had to fire her. We think the idea was that she was selling meth on the side. And I go, how is calling in sick selling meth on the side? He goes, well, we were trying to hint there was a problem. And I go, well, okay. So, yeah, that was a problem. So that was one of our lessons learned about, that was why clinics like to use their own staff. And so we in-serviced the research assistants in the clinics about how to do this, where it was going to work best, because we enrolled patients who were just coming in for a visit. They weren't coming in. We didn't recruit people who weren't already there. They were a patient at the clinic, and so therefore they were coming in for some other reason. They could have had a cold. They may have had diabetes. There could have been a number of reasons. And what should not be surprising to anybody in this room was we knew that literacy impacted knowledge. And at that time in 2007, it really impacted colon cancer screening knowledge, more so than mammography and breast cancer. And so when we looked at the results, one of the things that we found was, not surprisingly, the health literacy plus the nurse had a significant improvement. These clinics had between a 1% and 3% screening rate when we went in. So this was a huge increase. But if you notice in most of the arms, except for this little blip here, the screening rate goes down. So in year 2 and year 3, they weren't handed an FOBT in the clinic. What happened was it was mailed to them because patients don't always come back in time to get their screening. And so we mailed the low literate brochures to the patients who in the health literacy arm and the nurse arm, and then in the enhanced usual care, those were just mailed the FOBT kit, and they were mailed it in year 2 and in year 3 because the idea is if you're going to do an annual screening test, the patients have to do it every year. If you're going to use now what is the FIT, which is the next study I'll talk to you about, it's only good if you do it every year. And so trying to get patients to understand that they needed to return it every year. And so that was the results that we got on that. So what were some of the challenges we faced in these clinics? Community clinics aren't focused on research. They're focused on service for their patients. And so that was a hurdle that had to be overcome with in-services, with doing checkups on the RAs. It's kind of a catch-22 to hire somebody from the clinic because rural clinics, if somebody calls in sick on the staff, it's all hands on deck. And they pull from different, and so research becomes secondary because what they have to do is care for the patients who are coming in that day. But the great thing about hiring someone from the clinic was these patients knew that person. When they went to interview them and their provider, usually it worked best if the research assistants could get them before they went into to see their appointment. Our promise to all of these clinics was we would not slow them down. If it was in the middle of the interview and the patient got called, we would let them go back and they would finish it afterwards. So it had to be what worked for the clinics. The follow-up phone calls were feasible, but as many of you know, with low-income patients, their phone may be turned on the first of the month. They may use all their minutes. It gets cut off at the end. And so calling them back can be a challenge. What we found when we called them back to remind them, so they got follow-up calls from the nurse who would call them back and say, you haven't done your FOBT. Is there a reason you've done it, haven't done it? Most people had just forgotten to do it or they'd lost it, and so they would mail out another one. And at that time, LSU had public hospitals, and the wait time on a diagnostic colonoscopy back in 2007 to probably 2010 or 11 was a year to get in, and that was a huge issue. So one of the things that I would tell you that we learned from that study was it is important to have a strong relationship with the CEOs in those clinics. When anything starts falling apart, when you're not enrolling enough, when you have an issue, that is where they come in and are so vital. And with the clinic staff too, including the providers and the patients, and the material development was key. We needed the patients to feel like when they looked at it, this relates to me. I can identify who this is. And so the RA giving the recommendation in the FOBT before the PCP visit worked well because the provider just reinstilled that idea. I will tell you that as great as we thought our videos were, and they were 2 to 3 minutes, patients didn't want to watch them. I mean, they had gotten the information, and what they told the RAs a lot of times is, I don't have time for this. And so even though it would have been 2.5 or 3 minutes, and there were patients who were actually the ones who acted in them, they often passed on getting that. So that was a lesson learned for us. The nurse follow-up call to problem-solve screening was very time-consuming, just for the reason I said, and it's not cost-effective for these clinics. They're not going to hire a nurse, and these were RNs, who is going to be able to devote that kind of time. And so what we did was, also at that time, clinics didn't have EHRs, they didn't have electronic health records, they didn't have any way to follow up from the patients. And in 2007 to probably 2010 and 2011, patients were much more, especially women, were much more open to talking about breast cancer screening than they were about colon cancer screening. Now that has changed, the environment has changed, but that was one of the issues. So what that did was that led into our R01. And from that, what we learned, we took the lessons that we learned. Health literacy information was going to be standard in both arms. We knew that it was more effective. It had worked. There wasn't any reason to go back to using an enhanced usual care. And with colon cancer screening, one of the things that we realized was that the issue wasn't getting the first year screen when you handed it in the clinic. The issue became in year 2 and year 3. How could you continually keep patients doing a test? One is not done. And so that was the point of our second study, was to look at automated and personal calls. Did it make a difference if it was a live person, or would an automated call do just as effective? So once again, we worked with CEOs. This time we chose to work in South Louisiana. We went down and built our relationships before then. The phone call was recorded. I know y'all think I have a Southern accent. I do not have a South Louisiana accent. So the phone call was recorded by somebody from South Louisiana. We wanted it to resonate with the patients when they heard it. This is a breakdown of our clinics right here. That's just overlaid on Louisiana has no purple. This is the low literacy map. So we have lots of patients with low literacy. These were the materials we developed with the patients again. We spent more time. This is the FIT, which for those of y'all who don't know or not well versed in colon cancer screening, is a fecal immunochemical test. You take home, you do it. It's in place of a colonoscopy. At that time, rural clinics were not doing colonoscopies. They weren't referring. I mean, you had to have come in with issues that would have had your provider say you needed a diagnostic, because they couldn't get them anywhere close. If they were uninsured, they had no way of paying for it. So we took the FIT instructions and we simplified them. We took the CRC material and we simplified it. That's just the material again. What happened this time was everybody enrolled was given the health literacy friendly materials. They were shown by the RA in the clinic. We did the same thing. We hired people from within the clinic. They demonstrated the FIT for them, how to open it, because a lot of people don't realize that when you open the package on a FIT, it has lots of moving parts. You know, there's a little blue bag, and there are things that look like paintbrushes, and then there's this little panel that you have. So we tried to simplify everything. We put their names on the tab so they didn't have to worry about doing that. And we did everything possible to make it as easy for the patients to do. And so in year 2 and year 3, it was the same issue. And the one thing I didn't say was in year 1, if you went, the follow-up is if you didn't return your FIT in 4 weeks, you got a call. If you were randomized to the automated, you got an automated call. If you were randomized to the personal, you got a personal call. Then in years 2 and 3, it was mailed out to them. We sent them a letter a week ahead, and it said, just so you remember, you're in this cancer screening. We wanted them to, because it's a year, and a lot of people forget they're in a study. And we also did it on letterhead that had LSU and the clinic's name, so that they would recognize this was also coming from their clinic. And it said, we just want to remind you, in a week, you're going to be getting the FIT in the mail, and this is why you're getting. It's important to your primary care provider that you do this. Their primary care provider is their most trusted source. It is the person they rely on the most about health information. So then we would mail it out. They got the health literacy information again. And and what happened was that we kind of see the same thing. We could get them to get screened in year 1, and it starts dropping off in year 2 and year 3. Then this was the number of follow-up calls needed. So when they got it in person in year 1, they didn't need as many phone calls. By year 2 and year 3, they required a lot more phone calls. And so one of the things that we learned from this study was the regulatory paperwork, doing city training, getting on the LSU system. You know, we had to walk these research assistants through this. This is not something they're used to doing. We developed a simplified consent form and we trained how to do that. I did lots, and Terry went with me a lot of times. I did lots of face-to-face visit with these clinics. And so the deal was they needed a lot of hand-holding and a lot of re-emphasis on what was needing to be done. What we found was that providing the fit and the literacy improved it. Many more follow-up calls were needed in years 2 and 3. Automated call was just as good as the personal. I will tell you with older patients that they preferred the personal call was more effective than the automated, but overall it was. And so in ending, what I would tell you is that what has changed in these clinics, even during this study, they had not had electronic health records yet. And so by this time they got electronic health record. Louisiana took Medicaid expansion. Colonoscopy is now an option in these rural clinics because they have GI doctors going through them, and having clinics there. And so there are some more creative processes that can be used now that wasn't available then. Thank you.